everyone to Crescent Foundation's Equity Panel. I am Kyle Smith, co-founder and CEO of Crescent, and I am joined here today by an amazing group of panelists. I'm really excited to have everyone here today. But before we start, September is Sickle Cell Awareness Month, and currently Crescent is striving for 100,000, right? There are approximately 100,000 living with sickle cell disease. What Crescent would like to do is educate 100,000 people on sickle cell disease and raise $100,000, $1 for every known living person with sickle cell disease. So strive for 100K. You can follow us on Instagram at Crescent Foundation SCD. On Facebook, we are Crescent Foundation, a Sickle Cell Initiative, and go to our YouTube channel as well, Crescent Foundation. Our website is crescentfoundationscd.org. So with that said, we just felt it was important for us to hold a space to talk about equity in healthcare. Like I said, I'm joined by an amazing panelist online, but not on screen. We have Shirley Miller. Shirley has more than 20 years of experience in sickle cell disease, in program development, clinical trials, and patient advocacy. She has served on the Comprehensive Centers Clinical Trials Consortium, the NHLBI Sickle Cell Advisory Committee, as well as educational committees. Prior to her work in Charlotte, Shirley worked at the Southwestern Comprehensive Sickle Cell Center in Dallas, Texas, with Dr. George Buchanan, one of the many pioneers in sickle cell disease. She has established herself as a knowledgeable and confident speaker and advocate as it relates to living and managing a chronic illness, such as sickle cell disease. She currently works in Charlotte, North Carolina at Atrium Health, formerly Carolina's healthcare system, in an adult sickle cell program directed by Dr. Iffy. Shirley holds a Bachelor of Business Administrative from Northwood University and a master's in psychology from the Chicago School of Professional Psychology. She has served on the board of directors for the Sickle Cell Disease Association of America and currently serves at the NHLBI Sickle Cell Advisory Committee and the FDA Advisory Committee for the approval of new oncologic drugs. She is the author of the book entitled The Stranger Within Me, the story of her journey living with sickle cell disease. Shirley, thank you so much for joining us today. It's always a pleasure.
Thank you.
Next, we have Ray Blaylark. Ray is the founder and executive director of the Sickle Cell Foundation of Minnesota and the proud mother of a young adult son living with sickle cell disease. Since 2004, Ms. Blaylark has served alongside the sickle cell community, educating others and advocating for those affected by this disease. Over the years, Ms. Blaylark has tirelessly served as a patient caregiver, advocate, hemoglobinopathy counselor, got it, curriculum coordinator, trainer, program developer, grant writer, community planner, program evaluator, liaison, and community health worker for the sickle cell community. In 2015, Ms. Blaylark founded Sickle Cell Foundation of Minnesota as a means to increase sickle cell education and awareness, as well as improving outcomes in the clinical and emergency room settings, leading to improved quality of life. In addition to managing the work of the foundation, she also serves as sickle cell patient and family health advocate and care coordinator at Children's Hospital and Clinics of Minnesota, supporting more than 200 patients and their families. Ms. Blaylark is motivated by her passion, the mission, and her calling to this precious community. Her personal mission is summed up in the following statement, quote, "We fight for equitable access, compassionate care, and improved healthcare practices free of negative biases that impact outcomes. This isn't just my passion, this is my life. This is our life." Ray, thank you so much for being here today.
Thank you, it's a pleasure.
Next up, we have Tanya Ardawan. Tanya is a learning scientist and educational liaison who builds bridges across schools and medical institutions for the educational advancement of children living with chronic illness. She is currently a second-year doctoral student in the Mind, Brain, and Teaching program within the School of Education at Johns Hopkins University. Tanya is developing an intervention to redress the fragmented school and hospital model for students diagnosed with sickle cell disease, utilizing students' missed opportunities to learn as challenges to spur educational reform. She has many years of combined experience as a special educational teacher, juvenile court appointed educational advocate, and early intervention specialist. She is also the proud mother of 4 and grandmother of 1 and resides in Katy, Texas. Tanya, welcome. Thank you for being here.
Thank you for having me.
Next, we have Barry Gadson. Barry is a 31-year-old male who lives with sickle cell disease. He was diagnosed with the disease at the age of 6, and throughout the years has had many challenging times due to his illness. Today, despite sickle cell, he is healthy, has a beautiful wife, and amazing son. For Barry, sickle cell comes with many challenges. However, none of these obstacles has been bigger than him. Barry, my guy, thank you for joining us today.
Thanks for having me. I appreciate that.
And last but certainly not least, we have Dr. Wally Smith. Dr. Smith is the Florence Neal Cooper Smith Professor of Sickle Cell Disease at Virginia Commonwealth University, VCU. He also serves as the Vice Chairman for Research of the Division of General Internal Medicine and is the former Scientific Director of the Center on Health Disparities at VCU. Dr. Smith is an experienced implementation scientist and an expert in clinical and health services research in sickle cell disease. He has authored over 100 publications and served as an investigator on over 50 externally funded grants and contracts. Dr. Smith has been associated with the development of 2 potential lead compounds for sickle cell disease at VCU. Dr. Smith, thank you so much for your time today.
Thank you, Cal.
All right, so thank you everyone for joining us for this important conversation surrounding equity. When I think of equity, I think of access, I think of opportunities created for groups to succeed. I think of being seen and heard. This disease is a marginalized disease, a disease that not a lot of people have a lot of education and awareness on. We know that there are approximately 100,000 people living with sickle cell disease here in the US. This is a global disease. It impacts people of all different backgrounds and ethnicities. But when we are talking here within the US, it's predominantly those who are Black or Hispanic. About 1 in 13 Black people are living with sickle cell trait, and 1 in 365 Black people are living with sickle cell disease. So with that said, my first question is what does equity in healthcare look like for those living with sickle cell disease? Dr. Smith, I would love to turn this question over to you.
Let's start with money. There's about $6 per living sickle cell patient spent on research, public or private, as of I think it was 10 or 15 years ago, and the numbers were updated recently. And something like $3,000 per affected cystic fibrosis patient. There are only 30,000 cystic fibrosis patients. There are 100,000 sickle cell patients. So the number per patient is dwarfed. You just do the order of magnitude there. Equity would be the same amount per patient spent on research. Yes, we're moving past 6. Perhaps it's 12 now. Perhaps it's even 20. But it's certainly not 1,000. And so we could just start with that. I often say that, slogans are not enough. Sickle cell lives matter. Well, let's show me how they matter by putting some money where your mouth is.
Yeah, no, for sure. Before I comment, Ray, do you have any follow-up to that?
Yeah, in addition to that, I last year, working with the team that I work with at Children's, the last time I checked last year, we had gone from 11 times where cystic fibrosis research funds 11 times what sickle cell is, and now it's actually worse. It's 14 times because it has increased for cystic fibrosis, and it has not increased at the same rate for sickle cell disease. So that's absolutely, and I'm going to remind us in this conversation that equity is not equality. It is really meeting people where they are, and based on their need, providing what they need to get to that outcome. So in some cases, it might be more. The other piece is that the outcome shouldn't be different. If the outcomes for quality of life are measured for one disease state, it should be the same measurement for another disease state. So we see inequity in the outcomes as well. And between dollars and outcomes, they are inseparable.
For sure. I guess a follow-up question to that would be, what's the solution to finding these resources? Why aren't we able to attain these resources? What barriers are really put into place Dr. Smith, I'll kind of go back to you on this.
I think that you said marginalized disease, you said forgotten disease, and I think a telling statistic is somebody did a survey of a bunch of Black folks and asked them a few questions about sickle cell disease, and they couldn't answer some basic questions about genetic nature of the disease and about things like what are the symptoms of the disease. So if Black Americans are not aware of this disease, then it is truly marginalized. And I think we start with that and then we go beyond that. So if the titans of industry are becoming aware because there's a dollar to chase, and that's what's happening, I'll be honest. There's a dollar to chase now. Wall Street's become aware. And so suddenly sickle cell is cute and suddenly it's sexy, but it's not because of some genuine wellspring of equity or equality that people are chasing. They're chasing green, not Black.
Dr. Smith, you're getting ahead of us right now. You as always talking that talk that I love to hear. But no, for sure, I think that it's important for us to keep in mind that they have drugs to go to market now. And we'll talk about pharma in a bit. But I would love to kind of to shift a little bit, just in terms of maybe a patient perspective too. And Barry, I'm gonna just ask you, what has been some of your biggest challenges in terms of care? What are some things that you like to see change for adults living with sickle cell disease? And also, what are some things you've personally experienced, if you wouldn't mind sharing, that you feel shouldn't have happened?
For me personally, it's a number of issues. But we can just start by when you get to the point where you have to go to the hospital. Of course, we know, we're Medicaid. They do provide us with medication to take home. So when we get to the point where we have to go to the hospital, there's no reason we should be sitting in the emergency rooms, not even in the bed. I'm talking about we're just waiting to get back. I've waited north of 5 hours, easy, plenty of times. It's gotten to the point now where I won't go to the hospital at all. I haven't been to the hospital in probably 3 or 4 years because of that issue. They don't, and then when you do get there, they don't believe anything you say, pain related. And it's just this stigma that's tied to a lot of people with sickle cell, as far as, drug seeking and different things of that nature. But it's so many layers to it, man. We wouldn't be able to do it all in this call, but that's just to name a few.
No, I mean, like you said, it's so layered, it's so multi-layered, and it's a lot. And Shirley, if you don't mind, just from someone living with sickle cell disease, what's your perspective in terms of barriers that you may have experienced and things that you would just like to see more or better for that? We're not patients living with sickle cell disease. We're people who are living with sickle cell disease. We become patients when we enter a hospital, right? So when we enter that hospital and become a patient, what are some things you feel that have just kind of been neglected?
Well, to tell you the truth, I really haven't had that much problems when going to the hospital, but I have not been into the hospital. I haven't been in 15 years or so.
Wow, that's great.
To be hospitalized for a crisis. Now, I've had surgeries and things like that, but I really haven't had a bad problem. One time I went to an emergency room in another state, and the guy didn't believe me that I had sickle cell, and he gave me a pelvic exam because I was telling him my back was hurting very, very bad. Now, there's no way I should have had to suffer that when I'm telling this guy, and he was an African American too, so that made it doubly frustrating. So I basically just told my friends, just get me out of this hospital. This guy, he's in the emergency room. But like I said, I haven't had problems, but I have a nephew who has sickle cell, and he's in the hospital right now. And his wife told me, he was asked things like, has he ever been in prison? They tested him for like HIV, all kinds of venereal diseases before even trying to understand what may be going on with him. And that's to me is just downright discrimination. And that kind of stuff has to stop. It really does have to stop.
I remember when my son went into adult care, when he transitioned at age 21, his first visit, the nurse that was seeing to him before the doctor got to him, while he's writhing in pain, and my son has extremely complex pain that's hard to get a hold of, but he turned to me in the room in front of my son and said, "Did you give this to him or did his dad?" My son immediately started crying. It is to turn it into, to reduce it to that type of a conversation in the midst of pain is an insult to not just the patient, to the parents, to the caregivers, the family. But I also want to highlight something that Dr. Smith said about education, and we have some amazing education professionals in here. And one of the things that I look at is at the time that the sickle cell and newborn screening was adopted by the government, we've lost the understanding that it was the Black Panthers who pushed for so much of this education, so much of the testing. And it saddens me that what appears to have gone wrong is once we handed it over to them, we took our hands off and assumed that this government, who had already real clear ideas about who we were as people, or lack thereof, we assumed that they were going to do right by us without our input. And it seems to me that since that time, it has declined both on the medical education side and on the community education side.
Yeah. Kyle, could I just add, I'm sorry, could I just add one more thing that popped up into my head? Right now, as far as my medication goes, I'm being drug tested every single month. Now, I don't have a problem with the drug test. I get it. But when you dig a little bit deeper into what they're testing for, you're talking about cocaine, acid, PCP, everything underneath the sun they're testing for. And it just makes you wonder, you know, what is the motive behind it? You know, it's insane, man. I'm literally getting tested for cocaine and every other drug under the sun.
Honestly, it doesn't make me wonder. They're looking for anything else to blame it on so that they don't have to treat you humanely.
So I think also, I mean, on the other side of it, because I do work in a comprehensive center, it's dangerous to give you some drugs if you are on cocaine. And I do think that some of that is that, and I'd like Dr. Smith to weigh in on that.
Well, it's required that we test people on opioids, but why is it required? It's required because the CDC published data that said that people were dying from opioid overdoses. But I got news for you. It's not the sickle cell paper.
It's not the sickle cell. That's the thing, Dr. Smith. It's not
that
the
paper has been published.
Yeah.
So guess how many sickle cell patients are dying from drug overdoses per year? Just take a guess.
I couldn't even.
Under 10.
Yeah.
It's under 1%.
Yeah.
Under 10. The whole country, under 10 per year. And in the last, 20 years, it's been something like less than 100 in the last 20 years. How about low back pain? How about migraines? You could put a zero behind that. It's 10 times as much. So I think that people are suspecting sickle cell patients for no reason of being drug abusers and are looking under the wrong rock.
I want to say something to piggyback on what Ray and Dr. Wally said, and Barry and Ms. Shirley. The systemic biases and iniquities see this across institutions. So the stigma of being Black, and then there's it's a double stigma when you have sickle cell. So you have the stigma of the disability, or as people call it, a disability. I don't, but other people consider it that. And then you have the stigma that's placed on us for just being African American. And I think it just all really succinctly boils down to enacted racism. So within the educational system, we're not really working that well with the hematologists. We're not working well with the children's hospitals. There's just not good communication. And in many cases, the teachers, the staff, they do not understand, because they cannot necessarily see sickle cell, then they don't think that it's real. So many of the students are being referred for truancy to the court system because they are absent. And there's just a lot of barriers for them to be able to access their education, and they have missed opportunities to learn. So I'm not even so sure that our children need to be placed in special education.
Yeah.
How about if we just give them equitable access to education and to direct instruction, such as their peers that are physically in school every single day? And maybe we would see differences in outcomes, you know, education-wise. But we do have to have better partnerships, and we are really going to have to get at the crux of it, which is racist ideology.
Right, and Tanya, like you kind of,
when you add particular protocols such as the drug testing, such as, you know, on top of the opioid epidemic, to not just a stigmatized diagnosis, but a stigmatized people, you invite bias. You open the door wide open, because you've not addressed the stigmas, but you've attached you've attached protocols that produce even more stigmas. So this explosion, if we were to look at the data side by side, somewhere around the time of the declaration of opioid epidemic, you saw a humongous increase in the biases. You saw a humongous increase in the number of patients who felt that they were not being treated well, and they were not, and they continue to not be.
And Tanya, would you mind? Yeah, could you just talk a little more about, you know, those barriers that are external, you know, outside of the healthcare system, you know, that are being put into place for those living with chronic illness, those living with sickle cell disease?
Well, thank you for that question, Kyle. One thing that I think that we really need to if we just take a step back, like Ray said, if we look at us as a people of color, right? Just take sickle cell away from it for just 1 second. We know that in school systems, our children are twice as likely to be referred for, you know, with any type of disciplinary infraction. They're twice as likely to be referred for suspension or detention. So that's our school to prison pipeline. So we have that. When we talk about children with sickle cell, one of the things that I don't think the school system is paying close attention to, I'm sorry, I'm not sure if they really care. I'm not sure exactly what the, you know, I would have to take it back to racism, seeing things from a white perspective, from a white dominant perspective. But one of the things that is really problematic is that our children are stressed in school. So they have the stigma of being Black, they have the stigma of a disability, and now, like Ray said, we have protocols in place in certain school systems. As soon as the children come in and it's realized that they have a diagnosis of sickle cell, like for example, the Boston public school system, they immediately give the children and they put them on a 504 plan. So a 504 plan will give you direct access to special education services. We know that special education services are not equitable for us. It's supposed to be for our children to receive supports and things that will help them access the general education curriculum. But children of color are less likely, when they're in special education, to receive instruction that meets the general education standards. So it's not a protective factor for our children necessarily when they're in special education. So I have to say that. And I do think that there are factors that affect our children psychosocially, such as microaggressions, violence in school, from teacher to student, and even student to student. But I do have to say from teacher to student, because that's very under recognized, and there's a paucity of I won't say it's not research, but it's often not highlighted that is such a significant problem for our children and how it affects them mentally. So when you talk about learning is intertwined. Cognition and emotion, they're interconnected. Yeah. And so we really have to look at the feelings of our children, how they're feeling in school, what are their experiences, and the literature doesn't really talk too much about the experiences of the children from their perspective. The scholarly literature talks about the experiences of children from by proxy. Their parents have reported it. Yeah. And so we really have to talk to our kids. And I'm very excited about Crescent, because Crescent is trying to elicit the voices of people with sickle cell. Not I'm going to advocate for you and I talk for you and I use my own voice, because that's more hegemony, and we don't need that.
Yeah, Dr. Smith, do you? Yeah, go for it.
What happens? Let's raise a child real quick. So what happens is, starting early on, they get that 504 plan. They get told you're not normal. You can't play. You can't do sports. Oh, and by the way, we got a special teacher for you because you're dumb. And I'm not going to date you because you didn't develop your breasts, hair, and all those other things because you have pituitary ischemia and it's delayed puberty. So I'm not going to date you. And maybe I'll keep you behind a year in school. And also, I'll tell you that you're not going to live long, just to scare the heck out of you. Yeah. Is there any surprise that when they become adults, to a person, they need psychotherapy? They need psychotherapy for PTSD, for depression, for anxiety, for adjustment disorder, for issues of abandonment, all manner of things that our adults, and I'm talking young adults, 15 to 30, the mortality rate skyrockets for that group of patients once they leave home. If you survive the 15 to 30-year-old period, you come out okay. But surviving that period, that's really dicey. And you bring all of that risk with you, the psychosocial risk with you, and the biological risks of now trying to, live out your life as an adult with this same disease that maybe wasn't as severe when you were a child. So this group of transition age kids, they are at risk.
Yeah. Okay. One more comment, Tanya. Tanya, you can go, and then we'll move on to the next question.
Okay. I just want to thank you, Dr. Smith, for what you just said, and I want to ask you about. There seems to be an association between sickle cell. I believe it's a neuromyth, but there's an association between sickle cell and intellectual disability or cognitive impairment. There is not enough information or research being put into medical trauma and how the trauma of having a chronic illness on top of, which is exacerbated by all of these things we've already discussed. and just disabling language, deficit language that our children hear, and they get a lifetime of this. So could you please speak a little bit about trauma and how it changes the brain?
Yeah. I can also say this. The percentage of sickle cell patients who have a college education is much higher than you might think. There are a lot of people running around with 2, 3, 4 years of college.
That's right.
Who are adults with sickle cell disease. It's the percent. How about this? The percentage of patients that have college training beyond high school in the sickle cell population is higher than in the average African American population.
Wow.
Thank you. Thank you. I needed somebody to kind of just go to that and dispel that myth, because it's like kind of attached to us, and it's not real.
Expectation. They expect them to perform worse. And I know we're going to the next question, but I'd like to just add that many of these households these children are being raised sometimes by parents who the same thing was done to them in their educational experiences as well. And so they were disabled in their beliefs about themselves. And then it becomes generational, because that is oftentimes transferred to the children.
Man, yeah. So this panel, y'all are
this is dope. This is dope right here.
Y'all are giving everything, right? So, but Shirley, I wanted to come to you. I want to just shift gears a little bit. We talked about it a little bit at the top in terms of pharma and you know, just the amount of drugs that are really in, you know, the pipeline in terms of sickle cell treatment and the interest that we spark because they have a drug that is coming to market. You know, knowing that, you know, these different pharmaceutical companies are engaging with the sickle cell disease community and the history of treatment and curative therapies, or lack thereof, frankly, that this disease has had and quote unquote not had. Not even quote unquote, just straight up not had. What do you feel our obligation should be when we're approached by these companies?
Ooh.
Well, I mean, I think that we should be willing to participate, especially if they're asking us about designing a study, because we know better, you know, what's going to work when they're designing the studies and if it's going to be feasible for a sickle cell patient. So I wholeheartedly agree to participate when they ask me to, whether it's, you know, talking about the, you know, a design, or even if they just want to know, you know, after looking at the clinical trial, you know, what do we think about it? So I think that we should participate. I totally agree with it.
Shirley, do you feel that the patients who are participating are being misused, abused in any way? Or do you think that companies in general are empathetic to the plight of patients and really understanding that the patients are vulnerable and not used to this approach before in the past? Can you help me out with that? It's a fear of mine.
That the patients are vulnerable?
Yes, and will be misused. It's a fear. You don't have to agree with me.
Yeah, I mean, it's possible that they could be misused, but I mean, I think if you have a good relationship with your physician or your hematologist, and you trust them and you know that they're not going to ask you to doing something that you know that they may be harmed or whatever, it starts with the relationship. It really does.
It does, yeah.
And so if you have a good relationship with them, I think that most people will be, you know, feel comfortable about it. But the thing is, when we do informed consent, we tell them, you do not have to do this. And even if you say no, your treatment or your therapy is not going to be compromised in any way. And you have to make sure you spend time on something like that so they know they're not being pushed to do anything. It's really voluntary. They really don't have to do it. And
So you said something very important. Good relationship, that's a key phrase, with your keyword, hematologist, another keyword. Those problems are
Yep.
our problem.
Talk about it, Dr. Smith.
No relationship.
Nope.
Know your doctor, not even a PCP, and definitely know your hematologist. That's my fear. So that was a giant if. So of those 100,000 patients, how many of them have a good relationship with a hematologist that they can trust? And are we going to get to a place where the people who don't have those relationships are misused and are sucked into trials in some way? That's my question.
Well, Dr. Smith, too, we can even just talk about, how many hematologists are out there that actually have, extensive knowledge of sickle cell disease. Because hematologist, doesn't mean that you have extensive knowledge on sickle cell disease, right? It means you know about blood, and correct me if I'm wrong. Stop me at any point if I'm incorrect. But you have to have a hematologist that really cares about sickle cell disease. And also a hematologist that is an ally and an advocate, right? And recognizes that, this is a predominantly Black space,
Kyle,
and what does that look like?
Let me tell you what just happened to me. Now, you're talking about people being misused. They're trying to misuse me.
Not the man.
I have been after the hematologists in the largest hematology oncology group in the eastern part of our state to start taking care of sickle cell patients. I've been after them for 20 years. And do you know, only after Adakveo came out, the infusion drug, only after that drug came out did I get an invitation last week from the infusion center director, not even from a doctor, from the infusion center director of that large hematology group, inviting me to send patients there so they can infuse Adakveo in our patients.
Wow.
I think we have to be really careful about, and this is to Dr. Smith's point to Ms. Shirley, we have to be very, very careful when we are the access points for that type of data collection. People who do research have their own implicit biases. They design the studies, and I'm not necessarily talking about, big pharma, but just research in general. So the research is set up based on some type of premise or hypothesis that people have. And where does that come from? So research is never, it doesn't stand alone and apart from the political and the social, and the economic realities that are swirling around it.
I want to make sure the book Dying in the City of the Blues gets mentioned. It is thick and dense and hard to read, but we were talking about this 30, 40 years ago, and the City of the Blues is, of course, Memphis, Tennessee, but it might as well be Richmond, Virginia, or
it's everywhere.
Is that by Wiley? WAILOO? Is that?
Yes, it is. Thank you very much.
Yeah. Medical apartheid as well. We
Medical
have such
apartheid.
a lengthy history. And, I think sometimes what saddens me is when you talk about people who are resisting participation in these trials, what is the one thing that they'll bring up from the past that has happened to us?
It's the city.
Tuskegee trials, right? And yet when you look at the history of all of the egregious behaviors, that is one.
Yeah, I know.
I hesitate to use the word small, but medical apartheid is 400 and some odd pages, and that's 30 pages of it. And so not only have we a a historical reason to be concerned, but we also don't even understand the fullness of it. But the fact that they bring that one up, what happens is the same thing that we've talked about with disabling language. We've passed along the stories, but we have not passed along education about our rights, education about how we navigate those systems, so that we lessen the opportunity to be taken advantage of. And it's complex. It's not just a straightforward, but we don't always know what we need to know until after we should have known it. And that has put us at a disadvantage, because we walk into these situations, if we get that far, and we don't know how to hold them accountable to their own practice along the way.
Yeah, no, for sure. And I think there's so much that there's just going to have to be a part 2 of this equity panel. You know what I mean? Because we haven't even grazed the surface. We haven't even grazed it. It can go so deeper. You know, we haven't talked about community-based organizations and what our obligations are, you know, in terms of this fight for equity. The list goes on. Before we wrap up, I wanted to go around and see, you know, just for time purposes, if there were any final thoughts. I'll give everyone, you know, 2 minutes on just what they feel passionate about in terms of this disease, how we are or are not being served, and what we would like to see changed, you know, within our community. And Barry, I'm sorry, but I'm gonna hit you with this heavy last comment, you know, first. So Barry, do you have any final thoughts?
For me, it's basically what this panel is based around: equality, man. You know, recently within the last year, I don't mean to, you know, be long-winded, but to make a long story short, my old doctor retired. I had to find another hematologist. I called down to 8th Street, and they directly told me, we're not taking that doctor's patients, and left it at that. Mind you, I didn't have any medicine at this time. I'm scrambling everything. It's just not taken serious at all. It's almost like they look at us as a joke. There's no reason I should have been denied healthcare. I didn't have a hematologist at this point. There was no reason, and besides them telling me we're not taking that particular doctor's patients, and that's what they left it at. Now I'm actually in a pain management. I have a hematologist, but I have to get my medication through a pain management building. I'm used to going straight to my hematologist, letting them know what's going on, and he's accommodating me accordingly. But due to the circumstances, I'm in a pain management group basically for a condition I'll have for the rest of my life, which is crazy.
Yeah. Tanya, any final thoughts?
Oh, yes. Thank you, Kyle, because I was just typing to everyone my thoughts. I think that we do really need some attorneys to work with us, because I feel like this is a civil rights issue. It is much larger. It's across institutions, and those institutions are based on white points of view. Yep. And what's in the interest of white people. And so if we don't have necessarily the power right now, we are empowering each other and we are empowering ourselves. But if we don't have the power to fight systemic forces to where people will really listen to us and recoil from you know, a strong attack, then I think that we need to employ we need to really start looking at the laws and how these infractions are violations of our civil rights, and we need to do it collectively. Multiple grassroots organizations, you know, multiple school systems being examined.
Absolutely. Shirley, any final words?
Well, if a group told me they weren't taking sickle cell patients, I'd be happy, because I don't want to go there, because I don't know if I'm gonna get treated well or not. But I will find a hematologist and I will teach them how to treat me, because I have educated myself, and I will teach them. I will give them doctors they can call and consult with, you know. But I know it's not that easy in every part of the world. In some places, there's just deserts where you can't find a good hematologist.
Mm-hmm.
But consider yourself lucky if they said that they weren't taking sickle cell. You don't want to go there because they're not your friend and they're not going to give you the best care. But
Absolutely.
I mean, I know that it's like a double-edged sword. You know, there's a lot of discrimination still going on, even in this day and time, and it's ridiculous. As I told you when I first started the call, that my nephew is in the hospital right now, and I don't know, because of COVID, they won't let his wife see him. She can only look at him through the glass. And we don't know how bad he is. He's non-responsive. They said he coded one time. It's just not fair. But it's only because he's in this area where they don't have expertise. And so it's, you know, working out really bad for him. But we're praying that he's going to come out of it and things are going to be all right. But to me, education is the key. If you educate yourself, nobody can pull the wool over your eyes and nobody could tell you that this is what's best for you, because you'll know what's best for you.
Absolutely. Absolutely. Dr. Smith, final thoughts?
Well, I completely agree with Barry. We need more and better adult sickle cell providers. They don't have to be board certified in hematology. I am not. But they have to know sickle cell, and they have to be empathetic with patients who have sickle cell disease, and they have to be willing to listen to the patient and let the patient have a say in their own care. This is a disease like diabetes and like many other diseases that is basically managed at home. People only come to the hospital for 3% of their days, 3%. And yet they're probably in pain as many as half of their day. So they have got to manage their disease at home, and they need a doctor that can help them do that. And ideally, they need a medical home. They need a team with behavioral health care, social work, nurses, navigators, community health workers, community-based organization. They need an entire system of care. What's wrong with having that for sickle cell disease? We have that for hemophilia. We have that for cystic fibrosis. And we damn sure have it for cancer.
For cancer,
Yeah. Ray, final word. The floor is yours.
Dr. Smith no more.
I knew you can handle it. I knew you can handle it.
And really, if we have cancer centers, why don't we have sickle cell centers?
Amen.
If we have HTC centers, how come we don't have sickle cell centers? So that's one thing. I also made a promise to myself for 2020, even before the pandemic hit. I refuse to sit at tables that are only talking about educating doctors, because these doctors made it through medical school. They know how to do the research. They know how to study if they wanted to know. This is so much deeper than just the education. This is the heart. This is compassionate care. That should not be an issue for caring for another human being. We have to talk about racial equity and human rights, because if we're only going to talk about the one disease, we're going to leave out all of the rest of us's who have other underlying condition, when this is a matter of human rights. So I totally agree. I've talked about civil rights attorneys and other attorneys that deal with human rights, because we've got to get this right for our entire Black community, not just sickle cell, but sickle cell. If you can get it right for sickle cell, I do believe you can get it right for everybody else.
And that's why you had the last word, Ray. That is why that's why you had the last word. Ray Blaylark, Tanya Ardawan, Shirley Miller, Barry Gadson, Dr. Wally Smith, thank you so much for joining our equity panel and just really delving into this really rich topic and necessary topic. So thank you all for tuning in, and we will join you next time on our journey to strive for 100,000 lives. Thank you.
Thanks for having me.
Thank you.